Bismillahirrahmanirrahim. Now we are going to start the third session of the reproductive unit. So let's get straight into it. Firstly, we have the twins. So twinning, identical twins, identical or monozygotic zygotic twins, or fraternal or dizygotic twins. So in the case of identical or monozygotic twins, there will be a shared placentas and both of them will have shared placentas. So the dizygotic twins, dizygotic or fraternal twins arise from two eggs that are separately fertilized by the two different sperms, always two zygotes. We have two separate amniotic sacs and two separate placentas. So it is diamniotic, dichorionic. So it is for the dizygotic twins or the fraternal twins. That is, there are two ova in the mother's body, and the two separate sperms will come to form two separate zygotes. And those two separate zygotes will grow to two separate, these embryos, and resultantly we'll have two separate amniotic sacs and two separate placentas or the two chorions. In the case of monozygotic twins, only one ovum and one sperm is present, but the zygote gets split into two embryos, and that is why we have twins arise from one fertilized egg, one egg plus one sperm, that splits early in the pregnancy. Okay, twin arise from one fertilized egg, one egg plus one sperm that split early in the pregnancy. Okay, this is a basic concept. So let's move on. Twinning of cleavage. The timing of cleavage, sorry. In the timing of cleavage determines the chorionicity, that is number of chorions, and amnionicity, that is number of amnions. Okay, so it is scab, which means cleavage 0 to 4 days, separate chorion and amnion. Cleavage 4 to 8 days, there will be a shared chorion. Cleavage from 8 to 12 days, there will be a shared amnion. And cleavage 13 plus day, there will be a shared body or conjoined twin will be there. So you must keep the mnemonic scab in your mind, that if the cleavage is from the 0 to 4 days, like where is 0 to 4 days? So over here, like this one. So splitting is not a concern in the fraternal twins. The dizygotic twin is not dependent on the splitting process. The splitting is happening in the monozygotic twins. So if the splitting takes place 0 to 4 days, there will be dichorionic, diamniotic, as you can see that both the fetuses have their own chorion and amnion. If it is happening in the 4 to 8 days, in that case the fetuses will be monochorionic but diamniotic. So you can see the chorion, the chorion is single layer, but the amnion is, but both the fetuses have their own different amnion. If the cleavage is 8 to 12 days, monochorionic, monoamniotic, that is a rare condition. And if it happens more than 13 days, then monochorionic and monoamniotic conjoined twins will be seen. So let's see them now. Dizygotic twins. So here you can see in the dizygotic twins there is one ovum and a sperm that is separately that is separately fertilized from the other sperm and ovum, and both of them are separated independently, and then they go to the 2-cell stage, and then morula and the blastocyst, and ultimately the formed embryonic disc, and dichorionic diamniotic twins are formed. Okay, so this is the condition, and this condition is very similar, like in presentation, to the monozygotic twinning that happens from 0 to 4 days. Like even the monozygotic twinning that is happening from 0 to 4 days will have a dichorionic, diamniotic stage, but the catch here is the monozygotic twins will be identical to each other, but the dizygotic twins, although they will be born at the same time, they won't be identical to each other, because the genotype is genotype is not identical to each other. Genotype is different sperm and different ova are going to cause the formation of two embryos. So then we have this is the cleavage process, 0 to 4 days, 2-cell stage, and then morula, blastocyst, and all the stages are followed. If the cleavage started 4 to 8 days, that is after the morula. So within a single amniotic cavity, within a single, I don't know what that is. So inside a single blastocyst, two embryos started developing, and that resulted in a monochorionic diamniotic twins, and that is 75% of the cases. So 75% of the these identical twins are of this variety when the cleavage takes place after the morula formation after 4 to 8 days. Then blastocyst, Blastocyst is a condition in which the cleavage starts happening after blastocyst stage, and in this particular stage it is very rare, but we have monochorionic and monoamniotic, and in the case it happens after the formed embryonic disc, and after that cleavage starts, so that can result in the monochorionic and monoamniotic stage, that is conjoined, and that is also a rare condition. And you must remember that the mnemonic scab, and scab means from cleavage 0 to 4 days separate chorionic and chorion amnion, 4 to 8 days shared chorion, and then shared amnion and shared body, which is a conjoined condition. I'm sorry for the slowness of this process, but it is a very important table, so just keep this in mind. And now it is a very important concept that we are going to discuss now. Develop into arterial system. So aortic arch derivatives, they will develop into arterial system. So there are different type of aortic aortic arch derivatives: first, second, third, fourth, and sixth. So there are six. There are basically 6 aortic arches. Fifth one gets involuted. So the first arch, part of the maxillary artery and branch of the external carotid system. First arch is maximal. So first arch is maximal means that first arch is going to give rise to maxillary artery. Let me see where the first arch is. Okay. So the first arch is going to give rise to the maxillary artery. Second arch, stapedial artery and hyoid artery. Second will give rise to the stapedial artery. Then third arch, common carotid artery and proximal part of the internal carotid artery. C is the third letter of the alphabet. Then fourth one, on the left, aortic arch. On the left it will give rise to aortic arch, while on the right it will give rise to subclavian artery. Fourth arch, four limbs in systemic, and that is why the fourth arch, you must remember that on the left side the recurrent laryngeal nerve is going to that is the branch of the vagus nerve that curves around the aortic arch on the left side, while it curves around the subclavian artery on the right side. So that is, I guess, also a fourth arch derivative or something. Sixth arch, the proximal part of the pulmonary artery, and on the left only ductus arteriosus. So the sixth arch, the proximal part of the pulmonary artery, and on the left only the ductus arteriosus. Sixth arch, pulmonary, and the sixth arch is equal to pulmonary and pulmonary to systemic shunt of the ductus arteriosus. Okay, so these are the aortic arch derivatives. So here you can see that the table from the Uworld is stating that the aortic arch and adult derivatives. So first aortic arch will give rise to part of maxillary artery. Second will give rise to hyoid artery and stapedial artery. Third one will give rise to the common carotid artery and the proximal internal carotid artery. Fourth one on the left will give rise to aortic arch, and on the right side will give rise to proximal right subclavian artery. Then the sixth one is going to give rise to the proximal pulmonary artery on the left, proximal pulmonary arteries, and on the left specifically the ductus arteriosus is also coming from the sixth aortic arch. So 6 month postnatal, truncus arteriosus, then right recurrent laryngeal nerve loops around right subclavian artery, while the left recurrent laryngeal nerve loops around the aortic arch distal to the ductus arteriosus. So here you can see the common carotid arteries that is coming from the third pharyngeal arch and the not pharyngeal arch. It is coming from the third aortic arch. The fourth aortic arch on the right side is going to give rise to the subclavian artery, while on the left side it is giving rise to the arch of aorta. The sixth one is giving rise to the pulmonary arteries, and both pulmonary arteries are coming from the sixth aortic arch, and on the left side specifically it also gives rise to the patent ductus arteriosus, not patent but ductus arteriosus. It is also going to give rise to the ductus arteriosus, and so truncus arteriosus, where is that coming from? I don't know. Okay, let's move on. So the branchial and the pharyngeal apparatus. So embryonic structure which is key for the development of head and neck. These are the pharyngeal apparatus which is the key for the development of head and neck. So 3 components: branchial, cleft, arches, and pouches. Branchial cleft derived from the ectoderm, also called as the branchial grooves. Branchial arches derived from the mesoderm, muscles, arteries, and the neural crests for the bones and cartilage. Core mesenchyme, mesoderm connective tissue give rise to the cartilage, bones, and muscle. Neural crest cells give rise to neural crest cell migrate to center and gives rise to the cranial nerves. Artery will come from the aortic arches, as we previously have seen. Then the branchial pouches, which are derived from the endoderm. So here in this picture you can see the outer indentations, the green ones, they are the clefts. The pink ones, like this one or maybe this one, that is an arch, and the pouch is the inner indentation, that is this one. So on the purple one on the inside is the arch. The outer one, the outer indentation is called as a cleft, and I'm sorry, the inner something is the pouch. You keep your pouch inside your pockets and and maybe inside your bag. So pouch is on the inner surface, cleft is on the outer surface, and in between them is the arch. Okay, so this is from inside, so this is the gut section, so that is called the pharyngeal floor. And then inside the arch we have three things which are developing. One is cartilage, other is a nerve and artery. So these three things are coming from the mesenchyme, and we have 6 pharyngeal arches corresponding to the 6 aortic arches which you previously have seen. So let me see that. The embryonic structure is the key for the development of the head and neck. The branchial apparatus, 3 components: branchial, cleft, arches and pouches. Okay, scap covers outside to inside. So cleft, ectoderm, arches are coming from the mesoderm plus neural crest cells, and the pouches are made by the endoderm. So that is a very important mnemonic. Cap covers from outside to inside. The most outer structure, that is cleft, that is coming from the ectoderm. Arches are coming from the mesoderm plus the neural crest cells, and pouches are coming from the endoderm. So the branchial clefts derive from the ectoderm, also called branchial grooves. Branchial arches derive from the mesoderm, muscles and arteries, and the neural crest cells, bones and cartilage. Core of the mesoderm connective tissue gives rise to the cartilage and bone. That is going to give rise to cartilage and bone muscles, and the neural crest cell migrate to the center and give rise to the cranial nerves. Arteries coming from the aortic arches. Okay, so the branchial pouches derive from the endoderm, and let's move to the branchial cleft derivatives. First cleft gives develop into external auditory meatus. Okay, so the very first cleft is going to develop into external auditory meatus. Then second through fourth clefts form the temporary cervical sinuses, which are obliterated by the proliferation of second arch mesenchyme. Persistent cervical sinus will lead to the branchial cleft cyst. Branchial cleft cyst. It presents as a lateral neck mass below the angle of mandible, anterior to the sternocleidomastoid muscle, often noticed when become infected. Fistula to the skin made well and does not move with the swelling. So the movement with the swelling, if it is not there, it is branchial cleft cyst. Branchial cleft cyst will not move with the swelling. So let me see a picture of that. Branchial cleft cyst. Branchial cleft is also called the branchial cleft remnant of the brain. Okay, let me make it visible. Yep. So here you can see it, that the branchial cleft cyst, also called as the branchial cleft remnant or the branchial cleft anomalies, are a congenital condition that are present at birth in which tissue develop incorrectly or in one or both sides of the neck. Branchial cleft cyst sometimes have openings on the inside or outside of the skin that are called sinus tracts. Okay, so let's see the image. Just give me a second. It's loading it down. So this is the concept of the branchial cleft cyst, and branchial cleft cyst that happens because there is persistent cervical sinus that leads to branchial cleft cyst. So second through fourth clefts form clefts, the outer ones, right? So they form the temporary cervical sinuses which are obliterated by the proliferation of the second arch mesenchyme. Got it? Okay, the side can't be reached. I don't know why. So let's come back. So now we were talking about the branchial cleft cysts, and here we have branchial arch derivatives. So we already have talked about the clefts. So the first cleft develops into external auditory meatus. Second through fourth clefts form the temporary cervical sinuses which are obliterated by the proliferation of second arch mesenchyme, and persistent cervical sinus will lead to the branchial cleft cyst. Okay, then let's move on to the arch derivatives. The first branchial arch will give rise to the maxillary process. So we know that the branchial arch will form cartilage, muscles and nerves, and the arteries are coming from the aortic arches. So the first branchial arch will give rise to the maxillary process, maxilla and zygomatic bone, mandibular process which will make the Meckel's cartilage and mandible, and malleus incus and sphenomandibular ligament. Muscles, muscles of mastication, temporalis masseter, lateral and medial pterygoids, mylohyoid, anterior belly of the digastric, tensor tympani, anterior two-thirds of the tongue, tensor villi palatini. Okay, then cranial nerve CN53 will chew. So in the second branchial arch, let me see if there is a picture of that or not. There's supposed to be a picture in the Uworld. There's a very good picture. Okay, my internet is not connected. Okay, there is some trouble with my internet connectivity. So let's wait. So here we have it, like the picture of it. So the first arch will give rise to the maxillary process, as you can see in this picture. So the first arch is like the bony processes over here. Where is that? Okay, so the bony processes which are coming from the first arch, or the first arch of the branchial arches, the maxillary process like this one over here, and this maxillary process will give rise to the zygomatic and the maxilla. Okay, then mandibular process, this one, this will give rise to the Meckel cartilage and the mandible. And if you can see in the ear, so you will be able to see the inner ear bones, and from the inner ear malleus and incus, like the first two of the ossicles along with the sphenomandibular ligament, that is coming from the this one, like the first branchial arch cartilage. The muscles which are coming, if you can see in this picture, like the picture above, so the muscles of mastication which are drawn with the green, so these are the muscle of mastication, temporalis and masseter, lateral and medial pterygoids, mylohyoid, anterior belly of digastric, which is in the neck, and I guess they are drawn like over here. Inside the neck, if you can see, there is a green line, like over here you can see. In the neck there is also the green muscles. So those muscles are mylohyoid, anterior belly of the digastric, tensor tympani, and anterior two-thirds of the tongue, tensor villi palatini. The cranial nerve that is coming is definitely, we are talking about the mandible all the time. The muscles of mastication, so we need a nerve supply for the muscle of mastication, and the nerve supply of muscle of mastication is CN53. Talking about the okay, let's do it something like that. So talking about second pharyngeal arch, the second pharyngeal arch will give rise to the Reichert's cartilage. I don't know what that is. So Reichert's cartilage, stapes. Okay, so Reichert's cartilage will give rise to stapes and styloid process, lesser horn of Hoyt, and stylohyoid ligament. So that is basically coming from the Reichert's cartilage, and Reichert's cartilage will give rise to the stapes. Okay, styloid process and lesser horn of the Hoyt bone and the styloid ligament. If you can see in this picture, no, over here. So here is the styloid process, and inside the ear we have stapes that is also coming from the second arch. Like if I could zoom it further, so here you can see this is stapes that is red, and here is the styloid process. If it is not very clear, so kindly go to the PDF and open this picture. It is a picture from the Uworld, I guess, and that is very important. And for the muscles, now you can see that the muscles of facial expression like this one, and all of the muscles of facial expression along with the stapedius muscle, the stylohyoid muscle, platysma, and posterior belly of digastric, they are coming from the second pharyngeal arch, and the nerves which are supplying for the facial muscles, that is the seventh nerve for the facial expression. So the first arch is for the chewing, second one is for the smiling. Now associated abnormalities with the first and second pharyngeal arch include Pierre-Robin sequence. There will be micrognathia, glossoptosis, cleft palate, airway obstruction. So if I could show you the picture of this one, like this is branchial cleft cyst. Okay, so let's make it small, very small. Okay, so branchial cleft cyst. Here you can see that pardon me, the branchial cleft cyst, firstly it is located in the lateral neck, and secondly when the person will swallow, they will not move, they will not move up and down. So this is branchial cleft cyst, and that is developing because the second through 6th or second through 4th clefts did not involute. So the cervical sinus basically did not regress. Here you can see if there is persistent cervical sinus, that causes the formation of the branchial cleft cyst. Okay, second through 4th cleft form temporary sinuses. Now we were talking about the Pierre-Robin sequence. Let me bring out a picture of that. PI. So Pierre-Robin sequence, and remember it is a sequence. So in the sequence mean that there is only one intrauterine abnormality to which all of the findings of the syndrome can be associated. So here you can see in these pictures that the person or the fetus is having micrognathia. Okay, so there will be micrognathia, a small jaw with a receding chin, tongue is large compared to the jaw, resulting in the airway obstruction. So what are the findings, or what is the single association for all the finding in the Pierre-Robinson sequence is that suppose that this is a child with a small mandible, that is micrognathia. Now if the micrognathia is there, the tongue will be clustered inside the mouth. The tongue is also enlarged in these patients, and on top of that the tongue is cluttered or clustered inside the mouth. So suppose this is the soft palate, I'm just supposing it, and the tongue is this one in the normal patients, but if the tongue is folded inside the mouth, so that will hinder the growth of the soft palate, and that will look like something like this is soft palate again, and the tongue which is present inside the mouth, that will arch up like this. So if the tongue is present between the growing ends of the soft palate, the hard palate, the palate won't be able to fuse together, because in the middle we have the tongue, that is glossoptosis. So that tongue will lead to the abnormal development or lack of development of the palate, and that results in the cleft palate. Then airway obstruction, because the tongue is large enough and the mandible is small, so the tongue falls back, and that leads to the airway obstruction. And the other one is the Treacher-Collins syndrome, neural crest cell dysfunction that leads to the mandibular hypoplasia and facial abnormalities. Okay, so Treacher-Collins syndrome, the Treacher-Collins syndrome. Treacher-Collins. So the Treacher-Collins is like something like this. This is a characteristic picture of the Treacher-Collins syndrome, and you must remember this one. I guess my Google window was off. So this is Treacher-Collins syndrome, and let me bring back the picture of. Okay, so this was something that we were talking about, the Pierre-Robin sequence. My Google window was not working at that time, I'm sorry for that. So here you can see the fetus is having a very small chin, that is micrognathia. On top of that, the tongue has fallen back, that results in the airway obstruction. This is, I guess, is a picture from osmosis or something. Pierre-Robin sequence congenital birth defect that occurs during the fetal development. There will be glossoptosis, backward position of the tongue, then micrognathia, that is underdevelopment of the lower jaw, and airway obstruction because the tongue is obstructing the airway. Cause is not fully understood. Isolated genetic mutation syndrome, that is Stickler syndrome. For example, Stickler syndrome. Okay, so let's move back to our PDF. No. Okay. So, oh yeah. Yep. So we were talking about this first two pharyngeal arches, and we discussed that the first pharyngeal arch was giving rise to the mandibular structures, mandibular and maxillary structures, and the second was giving rise to the muscles of facial expression. Then the third one is going to give rise to the greater horn of the hyoid bone. So the greater horn of the hyoid bone is coming from the from this one. So let's bring it over there. The third one is drawn with the purple. So the greater horn of the hyoid bone, as you can see in this picture over here, so that greater horn of the hyoid bone is coming from the second pharyngeal arch. The muscles which it gives rise to are muscles of facial muscles of facial expression, but they were coming from the second pharyngeal arch as far as I remember. Yep, they are coming from the second pharyngeal arch. We are talking about the third one right now. So the greater horn of the hyoid, the muscles which are coming are the stylopharyngeus. Think of stylopharyngeus innervated by the glossopharyngeal nerve. Okay, so CN9, stylopharyngeus swallows stylishly. So CN9 is the glossopharyngeal nerve that is going to supply the stylopharyngeus muscle. So in this picture, the only purple muscle that is present is this one over here, the stylopharyngeus, like this purple muscle over here, as you can see. So this purple muscle is stylopharyngeus, and it is a third arch derivative, and it is supplied by the glossopharyngeal nerve, which is also a third arch derivative nerve. Okay, then we have the 4th to 6th branchial arches, arytenoids, cricoid, corniculate, and cuneiform thyroid used to sing ACCT, used to sing and act. So these are all thyroid cartilages: retinoid, cricoid, corniculoid, cuneiform, and thyroid cartilages. These are not thyroid cartilages; these are all the laryngeal cartilages. I'm sorry. So these are all laryngeal cartilages which are retinoid, cricoid. So you can remember them with the mnemonic ACT. ACT with three C's. So the fourth arch will give rise to most pharyngeal constrictor, cricothyroid, levator palatini. Sixth arch will give rise to all the intrinsic muscles of the larynx except for the cricothyroid. So since cricothyroid is coming from the fourth arch, so most of pharyngeal constrictor muscles and cricothyroid with levator villi palatini is coming from the fourth arch, while from the sixth arch that will give rise to all the intrinsic muscles of the larynx except for the cricothyroid. The fourth arch nerve is equal to CN10, that is superior laryngeal nerve, simply swallow. And sixth arch will give rise to the recurrent inferior laryngeal nerve, that is allowing for the speaking process. So for the CN10, the superior laryngeal branch that helps to swallow, and the sixth arch, that is CN10, recurrent inferior laryngeal nerve that helps to speak. Arch 3 and 4, posterior one third of the tongue, and arch 5 makes no major development contribution, so we don't talk about that whenever we talk about the arches. So it is like 1, 2, 3, 4, and then 6. So here you can see the fourth and sixth pharyngeal arches, like fourth and sixth, they have drawn them with a single color that is like kind of orange. So all the laryngeal cartilages are coming from the fourth and sixth pharyngeal arches. The fourth will give rise to most of the constrictor muscles, like as you can see over here, and most of the constrictor muscles are coming cricothyroid, levator, villi, palatini, and sixth arch for all the intrinsic muscles of the larynx except for the cricothyroid. So remember these things. And the fourth arch nerve is superior laryngeal nerve, while the sixth arch nerve is a recurrent or inferior laryngeal nerve. Recurrent and inferior laryngeal nerve, or maybe it's the same nerve. Okay. So I think we're done with this one, so let's remove it. So these are the only cranial nerves with both motor and sensory components, except V2, which is sensory only. So what's that? So the nerves, all of the nerves will have sensory and motor components both. Yep, except for the V2, which is sensory only. When at the restaurant of the golden arches, children tend to first chew, then smile, then swallow stylishly, and simply swallow and then speak. So the first pharyngeal nerve will allow the children to chew, that is the mandibular nerve. The second arch derivative nerve will allow them to smile, which is the facial nerve. The third one will allow them to swallow stylishly, which is the stylopharyngeus nerve, the stylopharyngeus muscle, which is supplied by the glossopharyngeal nerve, or simply swallow, which means that the superior laryngeal nerve, which is a branch of the vagus nerve, and then speak, which means the inferior or the recurrent laryngeal nerve, that is also a derivative of the 10th cranial nerve. Moving forward, we have done that. So here we have a box that is about tongue. So anterior two-thirds of the tongue, first and second arches, lingual swelling and tuberculum impar sensation. Tuberculum impar. So lingual swelling and the tuberculum impar. Sensation is CN5 of the first arch and CN7 for the taste, that is for the second arch. Okay, so the anterior two-thirds of the tongue is coming from first and second arches, and we know that the cranial nerve 5 and 7 are the nerves of the first two arches. So the sensation will be taken by the cranial nerve 5 and the taste will be taken by cranial nerve 7. The posterior third of the tongue, third and fourth arches, okay, so third and fourth arches will form the posterior third of the tongue. Sensory supply is by the glossopharyngeal nerve or the ninth cranial nerve of the third arch, and some posterior taste may be taken by cranial nerve 10, that is from the fourth arch. The motor supply is by the hypoglossal nerve, that is cranial nerve 12, and only one exception is there, that is palatoglossus will be supplied by the vagus nerve. Other than that, the hypoglossal nerve is going to supply all of the musculature of the tongue. Then we have the Treacher Collins syndrome. We have seen the picture of that as well. So the first arch syndrome, caused by the failure of the neural crest cells to migrate into arch 1. So if the neural crest cells are not migrating to the first arch, this characteristic finding picture of the child will be seen, resulting in underlying zygomatic bones, underdeveloped zygomatic bones, mandibular hypoplasia, and lower lid colobomas and malformed ears. Okay, so coloboma, what is coloboma? Let me see that. Coloboma. So coloboma, it is coloboma. So coloboma means Congenital abnormality of the membrane of the eyes. So does it cause? Coloboma is an eye condition that in the people are born with. It happens when the part of the tissue that make up eye is missing. It can affect one or both eyes. Okay, so coloboma of iris is something like that. So this is the coloboma of iris, as you can see here. Like, okay, so child has coloboma, talks to a doctor about the best plan of their care. The treatment can help maintain blah 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 blah. So this is something about the coloboma. Coming back, we have cause. Okay, so first arch caused by the failure of neurocrestals to migrate into the arch, resulting in the underdeveloped zygomatic bones, mandibular hypoplasia, lower eyelid colobomas and malformed ears. So if you can see, the eyelids have coloboma. I guess there is some piece of the eyelids that is missing. Then may lead to the difficulty breathing because of underdeveloped lower jaw. Again, it is similar presentation or similar causes that like that of the Pierre-Robin sequence. So due to the underdeveloped jaw, the patients with the Treacher Collins syndrome also have difficulty breathing, and obstruction of airway by the time can take place. So here you can see downward slanting palpebral fissures will be there. Okay, so in the case of Down syndrome, it is not related to this one, but I'm just talking about the Down syndrome because I have recently seen some patients in the wards. So Down syndrome have up slanting eyes, while in the case of Treacher Collins syndrome, the patient will have down slanting eyes. Hypoplasia of the zygomatic bones. Then there is microtia, that is small ears, coloboma of the lower eyes, and absence of the eyelashes medial to the defect. So wherever the defect is there, like wherever the coloboma is present, medial to that there will be no eyelashes. And hypoplasia of the mandible will be seen, and the hypoplasia is a causative factor for the obstruction and the things like that. So micrognathia, Pierre-Robin sequence, micrognathia, hypoplasia of the mandible. Okay, so you can see the mandible is hypoplastic. Let me change the color of that because only red is like, it's my favorite color and it's more evident in the ranks. So glossoptosis, posterior displacement of the tongue prevents the palatal fusion. So you can see that this. Okay, why am I doing that? Okay, so this particular tongue that is like clustered within the mouth, so it is not allowing the palatal fusion, and here we have the U-shaped cleft palate because these were supposed to fuse like here and here, but since the tongue was present between them, the fusion did not take place, and we have a U-shaped cleft palate. Then moving forward, we have the branchial pouch derivatives. So we talked about the aortic arch derivatives. Then we went to the branchial cleft derivatives. Okay, so the branchial cleft, the only branchial cleft that had some derivative was like the first one, which was giving rise to the external auditory canal or meatus or something. External or okay, the external auditory meatus was coming from the first cleft, while second to fourth were giving rise to the temporary cervical sinuses. And then we have it here. Now we are talking about the branchial pouches. So the first branchial pouch will give rise to the middle ear cavity, eustachian tube and mastoid ear cells. Okay, the first pouch contributes to the endoderm lining structure of the ear. So we know that from the pouch is from the endoderm, it is going to give rise to the structures which are endodermally lined. So middle ear cavity, eustachian tube and mastoid ear cells. The first pouch contribute to the endoderm lined structure of the ear. Okay, second pouch, epithelial lining palatine tonsils. Got it. Thirdly, the third branchial pouch, dorsal wings will give rise to inferior parathyroids. That is very important, that the inferior parathyroids are coming from the third arch, while the superior parathyroids are coming from the fourth branchial arch from the pouch. So the third branchial pouch is giving rise to the inferior parathyroids, while the fourth pouch is giving rise to the superior parathyroids. Okay, they are coming from the dorsal wings, both of them, but third pouch will give rise to the parathyroids, inferior one, third one is giving rise to superior parathyroid, while the fourth one is giving rise to the superior parathyroid. So suppose that here we have a thyroid structure like that. So the parathyroid are present dorsal to the thyroid, like behind it, two above and two below. So with this you must remember that they are coming from the dorsal wing. Okay, clear. Now the third pharyngeal pouch will give rise to the inferior ones, right, and the fourth pharyngeal pouch will give rise to the superior ones. Okay, now this is the final verdict. If I mess them up in the before, so just forget about that. Third is giving inferior and the fourth is giving superior. Okay, then the third pouch contribute to the three structures, and the ventral wings will give rise to thymus. Okay, so the third pouch contribute to the three structures: thymus, left and right inferior parathyroids. Third pouch structure end up below the fourth pouch structure. So third pouch structures will end up below the fourth pouch structure, and the fourth branchial pouch, the dorsal wings will give rise to the superior parathyroids, and the ventral wings, they give rise to the ultimobranchial body and the parafollicular C cells of the thyroid. So ultimobranchial body, what is that? Ultimobranchial body. Let me say that. Ultimobranchial body. So ultimobranchial body or ultimobranchial body, okay, or the ultimopharyngeal body is a small organ found in the neck region of many animals. In humans, it develops from the fourth pharyngeal pouch into the parafollicular cells of the thyroid to produce the calcitonin. So basically, the ultimopharyngeal cells will differentiate to form the follicular cells. So the fourth pharyngeal pouch is giving rise to two structures. You may say three structures. The first structure is the superior pharyngeal pouch, the superior parathyroid glands. The first structure coming from the fourth pharyngeal pouch is the superior parathyroid glands. Then the ventral wings will give rise to the ultimobranchial body, which will ultimately cause the formation of parafollicular C cell of the body, C cell of the thyroid. Okay, so now you can see the mnemonic: ear, tonsils, bottom to top. So ear from the first pouch, tonsils from the second pouch. Okay, the third one, bottom to top, means bottom for inferior parathyroids, ventral to thymus, and ventral to thymus, and then we have top superior parathyroids. So then we have to move forward to the Raynaud syndrome. It is an important one, and you must remember this. So just let me check how much time is left. So we have like 15 minutes. So Raynaud syndrome pathogenesis, chromosome 22q11 deletion will be there, and failure of third and fourth pharyngeal pouch to develop. Okay, the classic triad is thymic aplasia, that is T cell deficiency, recurrent infection. So whenever there is T cell deficiency, the person will be having recurrent infections. Failure of the parathyroid development will lead to hypocalcemia, and associated with the cardiac defects, conotruncal anomalies, outflow tract anomalies, for example, the tetralogy of Fallot or the transposition of great arteries. Facial abnormalities, small jaw, small upper lip and mouth, slanted eyes, low set ears, and can be associated with a cleft palate as well. So in these pictures, this is a picture of that of a child with a syndrome, that is Raynaud syndrome. So the conotruncal cardiac defects, so that is catch 22. So conotruncal cardiac defects and abnormal facies, thymic aplasia and hypoplasia, then the cleft palate and hypocalcemia. But I don't know what the problem with the child is, and that seems pretty normal to me. So cleft lip, what are the pathogenesis of development of cleft lip and cleft palate? So this is a picture for that. Cleft lip and palate have distinct multifactorial etiologies, but often occur together. Okay, so let's see this. Normal facial development, the frontonasal prominence, the purple one, then we have the lateral nasal prominence, like this blue one, and the like the gray or the green one, it is the medial nasal prominence. Then we have the maxillary prominence, mandibular prominence, and the stomodium, which is the mouth over there. Then week 5 we have maxillary prominence, like yellow one, and medial nasal prominence, the blue one. Nasal septum is there. Then primary palate is started forming, and the secondary palate is also started forming. So keep this picture in mind. Failure of fusion of the maxillary process. Okay, merged medial nasal processes which form primary palate and the philtrum. So the cleft lip is caused by the failure of fusion of the following, like the maxillary processes, which are like these ones, like the yellow ones, right? The maxillary prominences or these yellow ones will not fuse together, and that will give rise to the what? Merged medial nasal processes, which forms the primary palate and philtrum. Okay, so these structures will not fuse together. The maxillary process and the merged medial nasal processes, these structures will not fuse with each other. Resultantly, cleft lip will be seen. In the case of cleft palate, the neural crest has major contribution to the palate development, as there are number of molecular, mechanical, and the morphological step in involving the fusion of contributing structures. That is why it is considered multifactorial. So palatal development, primary palate, which is formed by the fusion of medial nasal processes forming the intermaxillary segment. It is also called as the median palatine shelf. It is formed by the fusion of medial nasal processes forming the intermaxillary segment. So the intermaxillary segment is over here, as you can see. Like this is the intermaxillary process. the red one, which is formed by the fusion of the medial nasal processes. Okay, then we have it here that fusion of the medial nasal processes forming the intermaxillary segment. It is also called as the median palatine shelf. The secondary palate formed by the formed from two lateral palatine shelves as a projection of the maxillary prominences. They both fuse with each other. They also fuse with the primary palate and the nasal septum. Okay, so the lateral palatine shelves, which are these ones, fuse palatal plates, and the palatine part of the intermaxillary segment, the palatine part of the maxillary prominence. Where are these are intermaxillary segment, right? So where are the later ones? These are the maxillary processes. So what did they say? They said that it is called the secondary palate is formed from the two lateral palatine shelves as a projection of the maxillary prominences. They both fuse with each other, and they also fuse with the primary palate and the nasal septum. Okay, so this means that the maxillary prominences, the maxillary processes, they will fuse with each other. Like these maxillary processes will fuse with each other, and they will also fuse with this primary or the intermaxillary segment, the primary palate. So the whole picture of palate is complete. We will see the problems later on. Let's first read it completely. So the causes of cleft palate: failure of fusion of the two lateral palatine shelves. So the lateral palatine shelves have not fused together, like in the case of the Pierre-Robin sequence, because there is glossoptosis and the lateral shelves cannot fuse together. Or failure of the fusion of the lateral palatine shelves with the nasal septum or the primary palate. So either the shelves, the lateral ones, have not fused with each other, or they are not fusing with the primary palate. Okay. So this is the problem with these with the cleft palate and the pathogenesis. So here you can see this is isolated cleft lip. How the isolated cleft lip forms? When the when the medial prominences of the when the medial maxillary process and the merged medial processes, medial nasal processes, they are unable to fuse together. So there will be an isolated cleft lip. As you can see in this picture here, the child is having cleft lip. Then isolated branchial cleft. Isolated bilateral cleft palate. So that is isolated bilateral cleft palate, which means that here we have an isolated U-shaped palate inside. So this is cleft palate, and that is isolated. Unilateral cleft lip and unilateral cleft palate, like the palate and cleft are not fused. So I guess then the pathogenesis in this picture is that the lateral palatine shelves, like these ones, they are not fusing with the medial nasal folds or the primary palate. And for the cleft lip, the problem is that the medial nasal folds are not fusing with the maxillary processes and something like that. So here you can see the unilateral cleft lip and bilateral cleft palate, and this picture is of the normal child with a normal lip and normal palate. Genital embryology. Fetal default development. Female is the default development, and mesonephric duct generate and paramesonephric ducts develop. So we are all females basically. The mesonephric duct degenerates and the paramesonephric duct develops. Okay, in the males, the SRY gene on the Y chromosome produces the testis determining factor and the testis development. Sertoli cells. Okay, so basically the presence of SRY gene will lead to the development of the primary genitalia towards the male, and the absence of SRY gene is determining the the pathway for the development of the genitalia towards the female genitalia. So it is the SRY gene that will determine the growth either into the male or female. Sertoli cells secrete the Mullerian inhibitory factor. So MIF is coming from the Sertoli cells that suppresses the development of the paramesonephric ducts. Okay, the Leydig cells secrete the androgens that stimulate the development of the mesonephric ducts. Okay, so for the male development we need mesonephric ducts, and the degeneration of the paramesonephric ducts. In the females, so opposite things are happening. So for the female, the mesonephric duct will degenerate and the paramesonephric duct will develop. While for the males, the Mullerian inhibitory factor will cause the suppression of development of paramesonephric ducts, and Leydig cells will secrete the androgen that stimulate the development of the mesonephric duct. Okay, then we have paramesonephric or the Mullerian duct. Development of the female internal structures, which are fallopian tubes, uterus, upper portion of the vagina, lower portion is coming from the urogenital sinus. So the paramesonephric or the Mullerian duct develops in the female internal structure. That is why the Sertoli cell in the males, they secrete the Mullerian inhibitory factor that leads to the suppression or dissolution, maybe what the word was, suppresses the development of the paramesonephric duct. So the fallopian tubes, uterus, upper portion of the vagina won't be developing the males, and male remnant is the appendix testis. Okay, so there is a thing that is called as appendix testis, which is the remnant of the paramesonephric duct, the Mullerian duct in the males. Then Mullerian agenesis, that is called as the Meyer-Rokitansky I can't pronounce that. Rokitansky-Kuster-Hauser syndrome. Okay, that is Mullerian agenesis, may present as primary amenorrhea due to the lack of uterine development in the females with fully developed secondary sexual characteristics of functional ovaries. Ovaries are functional, but there is primary amenorrhea because the Mullerian duct or the Mullerian agenesis has been there. So I suppose that in this particular case, the fallopian tubes, uterus, upper portion of the vagina and stuff like that, that will be absent. Although there are yes, although the ovaries are present and those ovaries are causing secondary sexual characteristics to form, but due to Mullerian degeneration, the female is having not having the female sexual organs or something. So let me see that Meyer, Rocky, Tensky, Kuster. Okay, Rock. Yep. So Meyer-Rokitansky, okay, Kuster syndrome is a disorder that mainly affects the female reproductive system. This condition causes the vagina and uterus to be underdeveloped or completely absent, although the external genitalia are normal, because we have seen that the Mullerian duct are responsible for the upper two-thirds of the vagina. The lower part of the vagina is coming from somewhere else. Affected individuals usually do not have the menstrual periods due to the absence of uterus. There is no uterus, and during the menstrual cycle, it is the shedding of the uterus that causes the blood to come out of the vagina. And if there is no uterus, there will be no menstrual cycle. Although the secondary sexual characteristic will be just fine because they are dictated by the ovaries which are present in these females. So let's come back to our PDF. Here you can see that mesonephric or the Wolffian, the Mullerian agenesis causes primary amenorrhea. Then mesonephric or the Wolffian cyst, or it's duct. Development of the male internal structure, that is except prostate, seminal vesicle, epididymis, ejaculated duct, ductus deferens, that is seed. So these structures are coming from the Wolffian duct. So boys are like wolves, and I don't know what is Mullerian. I don't know. So Wolffian duct is present in the males. Female remnant is a Gartner duct, and it is very important because it can Gartner duct cysts can develop in the females. So Mullerian agenesis and mesonephric. Okay, moving forward, we have this picture. So this is basically the common sexual organ of the fetus. So there are indifferent gonads, and then we have the mesonephros, and here we have the gubernaculum. Gubernaculum is the thing that directs the testes into the scrotum. Then we have the paramesonephric ducts, and then the mesonephric duct and the urogenital sinuses over there that will form the lower part of the vagina. So then we have it here that testis determining factor, androgens and Mullerian inhibitory factor, that is secreted due to the presence of SRY gene, and no androgens which is there because of absence of the SRY gene. So these result into epididymis. Okay, these are metanephric kidneys, so let's not consider them. So here you can see that the yellow structure which is formed by the paramesonephric duct, that is degenerated in the case of males. So what is prevalent? The paramesonephric duct is degenerated, but the mesonephric duct is there. Okay, so paramesonephric duct is gone, but the mesonephric duct gave rise to the testis and the vas deferens and the epididymis and all that. So urinary blood is coming from the urogenital sinus, I guess. And then in the case of females, if you look at this side now, so in this particular case, the mesonephric duct is degenerated, but the paramesonephric duct will give rise to the oviduct and the female reproductive system along with the uterus and upper part of the vagina. So these things are coming from there. And here we have the degenerated mesonephric duct. So M is for the males and M is for the mesonephric duct. So that gets degenerated in the case of females, and the paramesonephric duct will be degenerated for the males, and mesonephric duct will prevail. So remember this one. Then this table is very important. Firstly, we have undifferentiated gonads. Okay. Now there is a medulla and cortex. What's that? So the SRY gene will lead to the development of testes. Leydig cells will secrete testosterone. Okay, so the Leydig cells are secreting the testosterone that causes and certainly cells will produce Mullerian inhibitory factor. That Mullerian inhibitory factor will lead to the inhibition or suppression of the Mullerian duct. Okay, so here you can see the paramesonephric or the Mullerian duct that leads to the formation of internal genitalia. So internal female genitalia that is inhibited in the case of males. So Mullerian inhibitory factor will inhibit the growth of the the paramesonephric or the Mullerian ducts, and that is how the genitalia go towards the male development. And here you can see the testosterone. There is 5 alpha reductase, and yep, so testosterone is acted upon by the 5 alpha reductase that forms dihydrotestosterone, and that dihydrotestosterone will then make the external male genitalia, the penis, scrotum, and the prostate, and the Wolffian duct. Okay, the mesonephric or the Wolffian duct that gives rise to the internal male genitalia, including the seed one, like the seminal vesicle and epididymis and ejaculated duct and ductus deferens. So these are coming from the mesonephric or the Wolffian duct. So pardon me. So here you can see that what is cortex and what is medulla. I don't know if there is something over here like cortex and medulla. I don't know what they mean when they're talking about cortex or medulla. Maybe there is something in the text. So in the female with XX or genotype or no SRY, so there will be the formation of ovaries. Ovaries will release estradiol, and estradiol causes the formation of external female genitalia, that is clitoris and labia and distal vagina. So remember that these sex hormone testosterone and estradiol, they are causing the development of the external genitalia, while the internal genitalia are dependent on different type of ducts. Mesonephric duct in case of male, which is also called as the Wolffian duct, and paramesonephric duct in the case of females, that is Mullerian duct. So internal genitalia, fallopian tubes, uterus, and proximal vagina. So here we have SRY on the Y chromosome, SRY gene on the Y chromosome, that leads to the testis differentiating factor, development of the testis from indifferent gonads. So development of the testis from the indifferent gonads will then lead to the development of Sertoli cells and the Leydig cells. Sertoli cells cause the Mullerian inhibiting factor development, and involution of the paramesonephric duct will be there. So in the case of Leydig cells, we have testosterone production, and testosterone production will cause the Wolffian duct or the mesonephric duct to form male internal genitalia, epididymis, and vas deferens, and it directly causes the formation of male external genitalia, which is penis and prostate, genital tubercle and urogenital sinus through the DHT. So the testosterone directly causes the formation of external genitalia, but it also helps the Wolffian duct to be differentiated into the internal genitalia, which are epididymis and the vas deferens and stuff like that. So remember this one, and Sertoli cells are doing that. So remember it like this, that M is for the males, and so males have mesonephric duct, and remember females like female. So this will help you remember the P is for the paramesonephric duct in the case of females. So I am talking about the ducts which are persistent and which are responsible for development of the internal structures. So mesonephric duct for the males, which will cause the development of internal structures like the epididymis and the vas deferens, and the other one is the, what was that? What is with the S? So it is seminal vesicle, and then D is the ductus deferens. So these are coming from the mesonephric duct. While for the females, the internal structure, the fallopian tube, uterus, and proximal vagina, they are coming from the paramesonephric duct. Okay, and then the particular hormones like testosterone and estradiol, they will lead to the formation of specific external genitalia. So let's see it. No Sertoli cells or lack of Mullerian inhibitory factor that causes develop both male and female internal genitalia and male external genitalia. So male external genitalia will be there because that is dependent on the testosterone. But if Sertoli cells are not there, or the Mullerian inhibitory factor is not found, resultantly the child will develop both male and female internal genitalia, because the function of the Mullerian inhibitory factor, as we saw above, that was the Mullerian inhibitory factor that was produced by the Sertoli cells. The sole function of that was to cause the inhibition of the paramesonephric duct. The internal and external genitalia, they are dictated by testosterone. So if the person is lacking the Sertoli cell during the in utero life, so that results in the lack of Mullerian inhibitory factor. So these structures will be formed just fine, and along with that, the paramesonephric duct or the Mullerian duct, since it is not inhibited, the person will also have internal female genitalia. So 5 alpha reductase deficiency, there is 5 alpha reductase deficiency, resultantly inability to convert the testosterone into dihydrotestosterone, male internal genitalia, ambiguous external genitalia until puberty, when increased testosterone level causes masculinization. And here you can see now. So now we are talking about we did that, and now we're talking about the deficiency of this particular enzyme. So if that is deficient, the dihydrotestosterone will not be there, and resultantly the external male genitalia like penis, scrotum, prostate, they will not be formed. So ambiguous genitalia will be seen until puberty, and the male internal genitalia will be just fine because they are dependent on the mesonephric duct, so they are just fine, and they are not dependent on dihydrotestosterone, they are dependent on the testosterone alone. So there is if the testosterone is just fine, so that will cause the conversion of the mesonephric duct into external male genitalia like seed ones, seminal, vesicle, epididymis, and blah blah blah. But if 5-alpha reductase is deficient, dihydrotestosterone will not be formed, and resultantly the external male genitalia will be absent, and those external male genitalia, the absence of them will cause ambiguous genitalia until puberty, and after puberty the testosterone will cause the development or masculinization of those genitalia as well. In testes, lady leads to male, that is internal and external sexual differentiation, and certainly shunts down the female, that is internal sexual differentiation. Okay, so I guess it's time. So we will continue with the discussion of the uterine and the Mullerian duct anomalies in the next session. Until then, fi amanillah.